Hey guys, it's Casey here. Going to be doing my paediatric choking assessment now. Paediatric here, going to say they're less than 1 year old. So we're going to make sure our scene is safe. We're then going to utilise the correct safety precautions, make sure our gloves and glasses are on. We're then be doing our ETHAM report. We're then going to be entering the scene. We know the patient's choking, so we're going to be doing it in an orderly fashion. We're going to gain consent off mum that we're able to do what we're going to do, even though it's going to look harsh. We need to utilise these quite harsh measures to try and get the baby breathing again. We're going to do our AVPU, make sure the patient's alert, so at the moment they are alert. So then, because we can't encourage this patient to cough, because they are less than 1 year old, we're going to start with our back blows. So we're going to place them on our hand and start with the 5 pretty stern back blows. And then if they're still going after the 5, we're then going to be doing the chest thrust. So we can either have the patient flipped up like this and doing the chest thrust in the middle of the chest like this, or we can place them down on a hard bench and continue like that with our 5. Those 2 don't work, then we're going to continue to use those 2 until either whatever it is becomes unlodged or the patient does become unconscious, which is a bit scary, but that's what we're going to keep doing until we reach one of those situations. Patient has become unconscious, so we're going to start with our CPR and our IPPV. So we're going to get we're going to get my partner to start CPR, going to get oxygen, everything ready. While they're doing that, I am also going to call for backup and get us to get someone who has a bit more experience, someone who's able to do a bit more of the manoeuvres that we can to get here. In the meantime, I'm going to set up a laryngoscope blade, the correct one for the size patient I have, either a Mach 3 or Mach 4. So the patient is here, ready to go for our procedure here. We've explained it to mum, we've gained consent, told them this is what we need to do. So we've attached the correct blade with the light on. It's going to be a straight one. We're going to place it on the tongue, down on top of the epiglottis until we can open the airway. So we're going to place down with the force, the airway is opened. Once the airway is opened, with our other hand, we're going to grasp our forceps. At the moment we can see that there is a blockage there. It has been a little 5-cent piece, so we're going to, with our forceps, go down there, grab it there, making sure we're not levering off the teeth or the jaw to hurt the baby in any way. So we're going to go down, to pick up. If we can't get the blade on properly into the client's mouth, it's because we need to put them in a more suitable position, in a sniffing position. Maybe even rolling up some towels and putting some towels underneath to sit them up a little bit. So actually give us perfect angles to be able to put the blade on top of the epiglottis. Giving us a good traction, putting the forceps in again, picking up that 5-cent piece that we can see in there, dislodging it from the patient's mouth. Once we're doing that, we're going to make sure we have a suction ready in case the patient does vomit or aspirate. Making sure that my patient has that, my colleague has that ready to suction out at any time. Now that the patient is awake and breathing, we're going to put some oxygen on them from that oxygen that they were starved from those moments that they weren't breathing. So once we've done that, of course, we're going to take the patient, make sure they're stable enough, and then we're going to take them to hospital for some more monitoring and making sure that nothing happened while they weren't breathing. And that is my assessment.